ambulance company A, B, C, D that you're unable to provide them timely, that's fine. That's why we at Mount Sinai need to go and have our own folks and do that.
Well, the answer is I don't believe it's in the presentation, but yes, we do have patients waiting.
Okay.
And it is when we work with our providers, they tell us their resources, and if they can get the job done in time, otherwise, we either move on or do the best we can. It's not really been in our, nature to just hold. We know everyone has limited resources, so we just do the best we can. All we're asking is, during those times there's delays and resources are not available, we have the opportunity to fill that in. So yes, we have had delays like that.
Is there any reason why we don't have that information as part of your application?
It's available. We can,
Well, it's not here, and I'm told by the executive directors that I have to take the record as you submit it, and this is not evidence. It hasn't been positioned for me to see it, so I'm not worried about not seeing it. But if you're saying that, hey, we need this because it's going to help us, and we can't get it done, and we can't rely on ambulance service A, B, C, or D, then I'd like to have evidence that ambulance A, B, C, or D of this situation, redact whatever you need to redact, that have got that evidence.
Can I say something,
Please, Ms. Miller.
We're happy to provide whatever information you need. These witnesses who are all very learned and experienced in emergency.
Okay, if come up to the microphone if you could. And repeat what you said.
Sure. We're happy to provide whatever you request. And you can also take judicial recognition as a hearing officer of anything that we say, if you wish, here. Whatever the rules are for expanding on the application itself. We didn't know that you wanted this specific information. It's not provided.
And if I may, I didn't know that you're going to rely on ambulance services that were spending an hour, and that's the reason why you need to take this all in-house. So we have that.
We're trying to, I don't think we're saying that we want to take it all in-house.
Well,
I think we're
you
saying
want
the
to
opposite.
expand
But I
ambulance
think
service.
that we're happy to explain that the purpose of the hearing, as I understand it, is to explain our application
Absolutely.
and corroborate what's there. And we're trying to explain it in response to your questions. We're happy to do that any way you want. You can provide whatever information you want. If you think that there's something missing that you need, we're happy to provide it. We're not trying to expand the application, but we're going the direction that we started. You let us do whatever. We're happy to provide that.
Thank you. Further to that point, look, anything to respond? So I'm going to jump in a little bit further. I think, Dr. Ramsey, you had said in your remarks, and I'm going to paraphrase, something that that the increase in ambulances with Mount Sinai West will benefit all entities. I think you're talking about Fitney and
private, volunteer, hospital-based.
How is that going to work? How's that?
What I stated actually was that across New York City, there's going to be even greater needs of patient transports. And again, I want you to be focusing on not the traditional everybody who calls goes to a hospital. There's all these alternative areas where they may be transported to, or in fact, or the service is brought to them at their home. So these are all entities that aren't going to actually be part of the 911 system. So again, with the 911 system already stressed, and we want to fully participate in that, both in terms of our participation in EMS and collaborating with another vendor, which we're doing at this very moment. We believe there's, again, enough business for everybody, and that business will only expand.
If you could tell us, please, which other vendor are you collaborating with?
You really, so I can just go ahead and tell you that?
Well, that was
okay.
Sort of like, that would be the goal of my question.
Okay, so we saw, pardon me.
So,
I just want to make sure that was proper.
I mean,
So yes,
you raised it and I asked it. So.
Okay, good. So we're actually signed a contract for taking over the 4 CSLs of the Beth Israel site is senior care.
Okay.
And it's in Fidney's hands at this moment.
And how many ambulances would that include?
Four CSLs, and then, you know, the usual backup. And that's,
And that's how many?
and that's, and, go ahead, Kevin.
No, the additional contract.
Yes, and we already are contracted with Hunter on the discharge side, and we have an RFP out to even look at expanding that piece.
And we use multiple contract, I'm sorry. Maybe you want to talk about the transfers. So we use multiple vendors to do interfacility transports as well. And I think that, I mean, the issue that I think that we want to make sure that this is a paradigm shift that we're preparing for, and it's not unique to Mount Sinai. Like, all these other systems will be having the same increased demand. All these other healthcare systems in the region are looking at regionalization of care. This is going on across the country. It has not landed in New York City yet. We will be moving patients to specialty centers throughout the city and throughout the region, requiring new and more transport capabilities. This is not just 911. You're looking at a new model of providing health to the community that will be moving patients not just to hospitals, but to all of these other community providers, which will be another increase to the system. I hope we demonstrated that the system is currently not performing the way it is anticipated the response times would be, and that if you add more stress to the system, ask additional vendors to do all these other additional activities, the system will see another significant need with a lack of resources. We are trying to move with that paradigm shift and make ambulance services available to all of the boroughs of New York City to serve the patients we're responsible for, to make sure that they get to the locations that they need to get their care. We're being told we have to do this. Okay, it's not Mount Sinai's wish. This is going to be, you know, NYP and Montefiore and all the other health systems will be struggling with the same problem and trying to get their patients to the location so they have continuity of care in the community with their providers and to their hospitals, because we've been told we have to do that. And that's where we're trying to focus these new resources to make sure that we're capable of doing that for the New York City community.
Okay, and if I'm sorry, Dr. Evans, go ahead.
Do you mind if, you know, go ahead, maybe you had another question. I just want to make comment on something you asked
I'm
earlier.
going to shift something to what Dr. Jason's saying, going into the paradigm shift of population health.
Okay, well, it's perfect because I'm going to have Neem Gandhi talk to you. You made a mention about people of lower income or something like that coming to the emergency department. I want to make sure you know that we are agnostic to patients and their economic status. And I'll let Neem talk about.
And my comment was, yep.
Can I just finish? I'm going to let Neem comment on our involvement with specifically the Medicaid population, because I think it's very important to our mission, and it has a lot to do with what we're talking about, actually.
And Doctor, before you respond, if I could, I'd like to. This is one of my mea culpas. When I mentioned about some poor guy who needed help, it was unfortunate. And it was an unfortunate choice of word, apparently. It was not his economic situation that made my heart weep.
Yes,
it was the fact that he had unfortunately needed to have the head injury addressed. But doctor, go ahead and talk about Medicare.
Yeah. So I think Dr. Chasen mentioned this as well. You know, we believe that transporting patients to the place where they can get the most effective care, the highest quality care, is the right thing to do. That said, part of the reason why we're increasing, why you see the transports increasing, while you see the chart that we shared of populations that we're managing in each of the boroughs and that growing, is some of it is being driven, I'd say, at a high level by the federal government through the Secretary of HHS's, you know, assertion about movement to value-based care, but very specifically in New York, the situation we're seeing and that our colleagues at Northwell and Montefiore and other organizations are seeing, as well as what this what Medicaid has asked us to do with the delivery system reform incentive payment program with district is take on a broader population. We have over 300,000 members assigned to us, Medicaid beneficiaries assigned to us, where we have a set of projects that we need to complete to coordinate clinical care over the next 4 years. Actually, we're in the second year of that initiative as well. And on the other side of that, we have to be taking financial risk as a system for the outcomes for those patients. We've already actually more aggressively moved towards that alignment. And you know, when Dr. Munjal talked about community paramedicine, that's an example of something that we're using to meet patient needs where they are at home, or the transfer services when we have patients who show up at our clinic locations in the Bronx and they need a certain service to get them to where they need to be. I think the old hospital model was probably had a very narrow mission with regard to how hospitals were designed to meet community needs, and it was when a patient shows up at your door, deliver the best care you possibly can. And now we're being asked to, and you know, embracing the challenge to say, you know what, actually the community need that a health system is being asked to fulfill is not just for the patient that shows up at your door to deliver the best care possible. It's for any patient who lives in your community, get them to the place that can deliver the best care for them. And that's why you see that dramatic increase in patient transports, even within our system, saying, you know what, actually this patient who showed up at one of our hospitals can get the care better somewhere else. And rather than us just being paid for every encounter, we're embracing a broader need of, we're responsible for improving the quality for those patients. The state has given us targets to hit on that. And we're saying, okay, we need to get them to the best place so that we can continue to perform on that so that they can receive the care that they need as well. So it's kind of more, our mission is more aligned, I'd say, with community in this new paradigm than in the old world.
And following up, Dr. Gandhi, we're talking, so 7 ambulances plus 4 on reserve? I mean, it seems like you've got 300,000 people assigned to you. And are these sick people? Are these people who've already come into you for a deliverable of a service? Who are these 300,000
so these 300,000 are anybody who has had the model that the state uses to assign them, is anybody who has had the majority of their healthcare interactions, even if their interactions were very few, even if it was a single well visit with our system. So some of them are sick, some of them are fairly healthy, right? Some of them go in for an annual physical with a Mount Sinai physician somewhere in the community, and they've been assigned to us because of that. Some of them are very sick and end up in the hospital frequently. So it's a spread across the population. The point of this, the 7 and the 4 or the 11 or whatever the single digit number is and I think, and Dr. Shason said this, I think, is to, we're going to continue to partner with a variety of different organizations. We put out the RFP, we've contracted with some, continuing to do that, continuing to expand some of those services. Where we see the least ability to meet the patient's needs, that's where we want to be able to deploy a handful of additional resources to kind of shore up that need. So that's the idea behind what seems like a small number. We're to serve that 300,000 patients. We're going to be relying on the broad set of partners and continuing to use all of them, and increasing our requests of all of them. Hence the recent RFPs. So by no means do we think the 11 can meet the 300,000 patients. It's through the combined services of all the contracted resources plus our services as well.
Dr. Gandhi and Dr. Ramsey and anyone else on the team, could you enlighten us? Do you have any sort of projections, maybe that were included in the RFP, that indicate what your projections are for the need of these extra transport ambulances that will maximize patient A to facility B, C, D, and whatever that network and whatever that is? Do you have a projection how many people are going to need such maximize service?
So I can give a short answer, and Dr. Curtis might have something to add. We're still learning. That's part of why you see the transport volume growing as we learn more. I think it would be probably not fact-grounded for us to put out a specific number of the number of transports we believe, because we're learning more as we see the cases where it does make a difference, see the places where we don't need to do it. What we have is the historical growth in the demand for transport, where a physician has said, I can't do what I need to here, we need to get them to this other location, and that's the chart that we did include for the historical growth, but we don't necessarily have a top level projection of, when will that curve level out? We don't know.
Doctor, you had indicated, I'm staying with the RFP for a second, you mentioned that you had a few ambulance servers, you had 2 ambulance providers who meet together, but not individually, all your needs. Am I recalling correctly?
So the general theme on the RFP was we went to all those 11, right? And 5 responded, I believe. 4 responded. And none of them could meet all our needs of all the different categories that you saw up here, from 911 services to interfacility transfers to hospital discharge operations to these new models of healthcare that we're already starting to utilize in terms of, again, transporting patients not just to hospitals, but from dialysis centers to homes, nursing homes to dialysis centers, all the various pieces. So none of them could meet, no single entity could meet those needs, which I think speaks for itself.
So I understand. Ambulance services, no one ambulance service was able to do all the transports you needed?
Correct. In fact,
And what was the shortfall, just out of curiosity, without naming who couldn't do what? What was, for example, what wasn't?
so
being able to be
some
delivered.
could assume the 911 services, right? But they couldn't assume all the transfer services. Some could assume some of the discharge work and a little bit of the transfers. Abe, do you want to just comment just for a minute on how many how many vendors you actually use?
Well, for the RFP, nobody responded they could handle everything, and even say the vendor who agreed to take over discharge services, even now from within our system, they sub part of that out to even another vendor because they can't even handle the number of discharges that we're offering. So we're even seeing that, and so we're having to manage sort of that second level of measuring the quality and making sure that the volume is being met. And again, some of these needs, some of the delays we might see might be because some of the companies we're using, some of our partners might be doing a intrafacility transfer of a child going from one place to another, or doing just a transfer to get a patient to where the test needs to be done. We're at off hours and times where these companies might just not have an unlimited number of ALS units. They might be doing something that would keep them from responding to the STEMI or responding to the stroke. So even 1 or 2 ambulances in the right place will working in partnership with them make it better and easier and to take care of the patient in a timely way. So we've seen it at times where there's just no ALS unit or there's no ability, and we look and say, oh, they were doing this transfer for us there. That patient wasn't as sick, but you can't stop the transport in between and go take care of the stroke. So for all those reasons, to have that extra resource of our own unit to help, I mean, that's really important to us. And we're even seeing now that sometimes we call for not hypercritical cases, but just patients who need to be transported. We're just not getting the ETA that we hope for, and we're finding when people are busy, everyone's busy, and we wish we had another resource, and we want to be that resource is to be part of the effort.
Dr. Washer, before you go, if you expand to 12 or 24 more ambulances, could that also not be the situation where you've got a late night situation where you've got a very young patient needs whatever that you tell me the time of day, Saturday night, when this needs to be done, is that going to possibly be the situation if you have these extra ambulances and you run into that same situation?
It is quite possible that even with all the resources that are in the community and adding our resources, not every case is going to go on time, but it's going to bring us closer to that opportunity. So sure, and we're going to do our best to figure out where best to allocate those resources to get as many patients and the sickest patients taken care of. Yes, that is a possibility that even with what we're bringing in, the system still might not be able to handle the volume that we're going to generate with the acute cases, the need to get the patient to the right place, and all the programs that we're going to be developing with population health. That's definitely possible.
Okay, thank you for your honesty. Dr. Ramsey, I'm going to ask one more question if I can.
Sure.
Of a general nature before I open up to people on the committee here. There was a similar application by a different entity a month and a half ago, and I raised a question then, and I'm raising a question today. What does the fire department think of your request?
Yeah, I was here for that
I recall.
event, right. So the fire department, as you know, will not take a stand, and they will take a neutral stand officially on any of these hearings and their outcomes.
Okay, and for the record, I do not know that, but I know there's an absence of fire department participation in these hearings, and they don't tell me a whole lot.
Yeah, they let me know that.
Okay.
Yeah.
Well, I don't, but we don't have them present today, but
Right.
we don't have the information on beyond what we believe they believe.
Right.
Okay. I thank everyone. I'd like to open up. I'm going to go with Mr. Marcelino. I started on my left. I'm going to continue with my left.
Okay, good afternoon. I'm a little vexed.
Oh,
Are you
Sorry.
looking to do a pre-hospital care system, or are you looking to do an inter-facility system?
we're actually looking to expand our services to reduce, we've talked about this multiple times. So there are different arms of patient transports, correct?
I'm
So we
very
have,
familiar with this.
yeah, I know you are. So I just want to be able to explain, and we'll let others explain as well. So as you know, we have the discharge piece. We have transports, not even to hospitals, but from one entity to the other in terms of one place to the other. We have the EMS part, and we have the transfer part. So what we are looking to do is we are looking after an analysis, and certainly based on the current stressed 911 and 911, non-911 services that are available, we are looking to diversify and become less vulnerable so that we can take care of all the patients that we're responsible for. And frankly, by doing this, we'll also help the system in general take care of New York City's patient population. I just want to have Kevin just respond as well.
So to better answer your question, we're looking to do a pre-hospital system.
It's mostly pre-hospital and not inter-facility.
It will be both services, but it's to design a larger pre-hospital system.
So it's designed for a larger pre-hospital system, correct?
Yes.
So if we're designing a larger pre-hospital system, the amount of vehicles that you're looking at, also covering the territory of the city, which encompasses 5 counties, where do you propose to put these ambulances?
So based on some of the information that we've discussed, that we are evaluating our system, and we'll have to better understand the needs of the community to have a matrix type of approach of applying these ambulances to places where, where Dr. Washer is having difficulty moving patients this month because of some situation. That needs to be dynamic, and tomorrow it might be a facility that is over capacity, and we may need to move patients to other parts of our system or to other places for care, and we may need to mobilize those resources in another location. So it's a dynamic matrix type approach where we will deploy these ambulances to the facilities or to the places where those resources are needed.
Are you looking at locality based?
We're looking more at strategically based. And again, it's dynamic. So it doesn't have to be always in the same place.
Pass this on. I also, one quick question. I noticed that you mentioned RFP a number of times during this hearing. Did you give us a copy of the RFP?
We have reference to it in your application.
We have a copy of it in the application.
I don't think you do, but we can certainly provide it to you.
I'm going to pass it on to my colleagues.
I think just one question. I know it was asked in previous hearings, and it's been in my mind a lot too when we go for the expansion of the certificate of need. Have we tried other methods of getting expansion? I don't know if we asked that just yet. I might have missed it. It's probably in the application.
It's a good question. Okay.
So I just want to make sure I understand your question. Are you asking, do we look at other methods to obtain a CON for the 5 boroughs? Is
Yes,
that what
we're
you're asking?
purchasing a different certificate to cover the 5 boroughs.
Yes, we are looking at that as well.
Well, there was an option out there, that's all.
John? In the utilization and operating revenue budget estimate for year 1, the transport volumes, you're indicating,
And Jim, if you could just tell us which attachment, or
it's one of the pages in here, it's unnumbered.
is in the primary.
Yeah. It talks about transport volume, emergency transports of 53,252. That's an estimate for year 1. Is that for the current system?
That's current.
All right. Are those interfacility transports or 911 transports?
Strictly 911. Okay. The in-facility transports are in a different part of the application.
Okay, the
And
non-emergency transports are listed as 6,900.
current.
The estimate for, I guess, 2016.
That's actually 2015 numbers.
Okay, so what would be the estimate for 2016?
I thought that was in there. I believe it was, I'm basically positive it was in there, but I believe about 6,900.
All right, that was the estimate for 2015.
I'm sorry, so then it was 79. I think we went up by 1,000.
Okay, these would be the interfacility transports.
Correct.
Well, if you compare first quarter 2000, just if you compare it just for our transfer volume for 2015 to 16, the first quarter, there was a 20% increase. So I can at least give you that. Look, it might not be the same for every quarter, but that's what we saw comparing quarter to quarter Q1 2015 and 2016. And a lot of that does have to do with the increase in bringing patients from the population health piece of this rather than just moving patients.
All right, this would be going out to a doctor's office, picking up a patient, and bringing them back to Mount Sinai Hospital.
A combination. That we deal with urgent care centers picking up from affiliated hospitals, and within our own system, it's a combination of all those round trips.
If they would have to go to a hospital, would they go into the 911 system for an ambulance dispatch?
Well, if they're within our hospital system already, they definitely would not. Part of what our goal is to have the ability when patients need to come from an office and an urgent center, not to stress the 911 system further, but to have that transport capability with some of these units to get those patients from our affiliate, from an office to a center without having to call the 911 system when that would be safe and appropriate.
And the 11 commercial ambulance services in New York City cannot handle this 6,900 call volume.
I mean, I can even give you an example that we work